questions or comments, you put it in the chat box so that we know how, and chat box to be addressed to everyone. This is a single thing. Angana, I think we are nearly there. Give a quick instruction and then we're going to start. Got just a minute to go. And Angana, can you see that the echo part what Dr. Sangjog was talking, Dr. Kalra was talking, whether that can be minimized from the technical point of view?
I don't hear it anymore, actually. I think it was just someone had their speakers on and there was a mic that wasn't on mute, then that individual's muted it.
You are right. You see, I'm not hearing either. We can see a lot of people are entering. The audience is increasing, sort of good number of audience you can see coming and joining us in this meeting. Angana, 7 o'clock. Are we ready to start?
Sir, participants have joined in. We are the speakers are already in. So
yeah, we are ready. When you are ready, we are ready.
So I think you can start the proceedings of the meeting.
Okay.
Sir, Angana is checking with Dr. Roy right now. So we can wait for a couple of minutes maybe and then start.
Can we please record the session and send it to each and every one of us?
The technical thing, I think this program is supposed to be recorded as per my.
It is getting recorded.
It is getting recorded.
Yeah.
And you will get the proceedings, and it is minuted also. And we'd like to have your feedback, and we'll come out with some version, e-version of your suggestions, and then circulate. Then it will go into circulation. And this is
how are things coping in Kolkata after the cyclone?
Oh,
you guys doing okay?
Just yeah. We had a bit of problem, but anyway, today looks good to me. We had a bit of problem with the internet this morning, but eventually it sorted out. The other thing I think is important for everyone to know that this the chamber, the Bengal Chamber of Commerce, is the oldest chamber in India. I think it is. It started when Angela's predecessors used to rule our country. So it's the oldest one, and got tremendous contribution towards every front of the society: health, then business, entertainment, travel and tour. They got significant sort of communication, music. It's a huge area, and I wish if you see our management committee meetings, phenomenal. Angana?
Yes, sir, we are ready to go.
Sure.
You may please invite the speakers one by one. We can directly get into the actual technical part of the program. So we can invite the speakers one by one and take it forward. And before that, if you can hear me properly, I would just like to mention our technical moderator here. They're muting all the participants so that the proceedings can be taken forward seamlessly. and the speakers will be unmuted so that they can, address their session.
Good.
And if you have any questions and queries, you may please write it in the during the interaction, and the moderator, Dr. Rabin, will take it correctly. Thank you.
Okay, so should is Dr. Rai giving an opening remark, or shall I start?
I'm not being able to identify him. I think there's a connectivity issue. I would request you to take forward with the program.
Right. So thank you. So, and ensure that this program is being recorded, and also some of the things can be minuted so that we can discuss in our health committee meeting, and then pass the information, pass the recorded thing to the faculty to get their feedback. Right?
Yes, the meeting is being recorded, and transcription will be made from the recording.
Excellent. So with that, we're going to start. So good evening from India to everybody, and also good morning to the faculty in the United States, and good afternoon to Angela in the UK. So I think we need to understand that it is very important that we are going through a very critical time, and it started, say, let's say from early March or maybe late February. And later on, it was declared kind of an international disaster by WHO. There was a lockdown in the entire world, and a lot of hurdles, the clamping of the society. People are in isolation. There's the fear, there's the anxiety. But having said that, we also realize that life has to go on. Life has to continue, because the finance got affected, the production got affected, manufacturing got affected, and non-COVID people could not be catered properly. So now the time has come. I think every country is thinking this way, that now probably we should open it up, maybe in a gradual manner, but at the same time we should take care for ourselves, as well as all activities of the society, of the community should start slowly for in the production line, in the service line, in the education or an academic line, and in the construction line, and every line. With that kind of small introduction, may I request our first faculty, Professor Dr. Rakesh Yadav, Professor of Cardiology, AIMS, All India Institute of Medical Science in New Delhi, to talk to us on COVID-19 and we Indian today and tomorrow. Professor Yadav, all yours.
Thank you, Dr. Rabin. And I have shared the screen. Can anybody open the shared screen? If
yeah, we can see your presentation very clean. No problem.
Now, we all know there's a book written by Angus Deaton in 2013. He's a Nobel laureate, Great Escape, Health, Wealth, and the Origins of Inequality. And what he mentioned, that the consequent investment in public health system involves sanitation and disease surveillance, played a bigger role in improving life expectancy in the 20th century than gain in income. That is, I think, is a very important comment by that person, that we all believe that life expectancy is increased by improving the medical facility, by improving the income of the society. But the real crux is is a public health system. Now, it's very, very important in India, because the improvement in health system were not uniform, especially in India, going to urban, going to rural population, interior population. So it is not being uniform in India. And see, there's some statistic. Death from contagious disease in India are much higher than the global average. And we are just behind Pakistan and South Africa. In 1929, Global Health Security Index measured countries' pandemic preparedness on a score of 1 to 100. And we are at 57 out of 195 countries. This is very, very important, that India is more vulnerable to epidemics compared to China and Italy, the most affected the COVID-19 episodes. Now, there is some criticism, maybe our wrong health policy or lack of resource. I'm not going into detail of that, but that is very important, because India overall expenditure on health is 3.6% of GDP. And only the government spend 1%, which is very, very less, and 2.5% is from health expenditure, from out-of-pocket health expenditure from India. Now, this is also a very, very important thing. We have two important disease surveillance program, the integrated disease surveillance program and the health management information system, which still is in infancy and finding the manpower, the resources, the well coordinator. If you see the CAG report of 2017, which find that health management information system was often of poor quality, riddled with gaps and contradicts by the physical record maintained by health centers. So, and this is also a very important statistic which we always see, that preventive care out of whole of the healthcare function, only 6.8% is expended on preventive care, and more than 80% is expended on curative care in India. We all know the best defense against any pandemic is a strong health system. And we believe that the recent data, the Indian response to COVID-19 pandemic is one of the most stringent in the world, and we score 100 after score. And this is a compliment we have to give to our government, that at present they are acting very, very fast. But what are the problem? Let us give a problem-oriented few questions to all the audience and to all the August speakers. What is the problem in India at current, in which we are not able to fight COVID-19 as we thought of before starting of this pandemic? And the most important is a lack of, I will always say, scientific uniform health resource and infrastructure at our level. People say, yes, our infrastructure is very good. I'm in All India Institute of Medical Sciences, who caters about 10,000 patients per day, and which have all the good infrastructure. I don't deny it. But if you go to primary level, secondary level, and tertiary level, all in three levels, if you go all across the India, we have no uniform scientific resources and infrastructure. Why I always say scientific? Because the data is that India has, in Delhi itself, we have 75% quacks who are practicing in Delhi. It means they are not scientific health resource for us, though there's a lot of argument that they are treating the people, but actually they are not scientific health resource for us. The second important thing is, because now initially it was believed that this COVID will only affect the urban population, because nobody is traveling, the rural person is not traveling about, and this is an airborne disease. And I always say this COVID came to India by air only, by planes only. Nobody can go walking to China or any other country and come back. So it is an airborne disease, we all believe, and people believe that a rural health population will never get it. But what you are seeing nowadays, 40 million migration of the laborer from the urban area to the rural area. And we all believe that the surveillance of this thing is practically impossible. And I always believe that just taking a temperature at any place and saying that this patient is COVID positive, COVID negative is practically impossible, because this is a very scientific meeting. So I can disclose this thing in the scientific meeting, though I cannot disclose these things in a public, because there will be panic in a public that you cannot screen these patients. And it is very true. By taking temperature with a sensor, it's not going to say it is a COVID positive or negative. So this migration is very, very important. And why it is very important? Because our infrastructure as primary level is insufficient to tackle the COVID situation at present. Second important thing, lack of equipments, lack of PPE kits, lack of drugs, lack of ventilator. Though government is trying our best, they are buying 40,000 ventilator, but we know it. The ventilator is not a machine which can be tackled by everybody. You have to have a trained anesthetics, and I don't think India have more than 50,000 trained anesthetics. So these are all things which we have to think. We have to think that buying these things is not going to solve this problem until you prevent this. And I appreciate the Kerala government response to COVID-19. And believe me, Kerala government in recent days not finding a single new cases, because they have a very good primary healthcare surveillance system, because they have faced the Nipah virus and a lot of virus in the past. So they have a very good primary healthcare surveillance system, and we need in this country basically a primary healthcare surveillance system and treatment system. Second important problem in this country is not only the healthcare system. The most important problem again is the poverty, and the poverty leads to overcrowding. In a Dharavi, which we are getting about 2,000 positive, people say that Dharavi cater about 15 lakh labor or people who is living in that small slum in Mumbai. And out of that, 85% go in a public toilet. So you can believe it that the crowding ought to occur in these places because the public, everybody need a public toilet. So in the morning, there will be crowding there. So 80% of a Dharavi population goes to a public toilet, though no have a private toilet. Second important thing, major transportation in this country is a public transportation. It is not a private transportation. You see the bus, you see the metros, you see the trains, they all are overcrowded. Third important, though the government has taken a very serious effect in improving the sanitation of this country, and Swachh Bharat is a very, very important program of this government, and they are trying their best. But you need that the concept of sanitation takes time to come. It is not switch off and on that you plug the money and the public will start doing a good sanitation. It is a mindset which need to be changed in a sanitation. It is a mindset. And I think it may be possible that the government approach to these all things is becoming growing, and in near future, I think we will have a good sanitation in all over country. Then fourth important thing, our public awareness. We are mainly guided by the quacks, by the wrong information, which is propagated by the media, by the WhatsApp. There's no clear-cut public awareness program going on, though the government is trying their best. But in practicality, if you see, the public awareness program is very important. I can say you one example. In a society which is a very reputed society, the people believe that if a person is coughing in balcony at 4th floor, the 1st floor person get infected. So people are not coming to their balcony itself. People believe that if a person has jogged into the jogging area hours back, and if you go and if it's corona positive, you can get corona. And this is not an uncommon thinking of the public. It is a common thinking of the public. So the awareness about COVID-19, and I will always say correct awareness of COVID-19 is very, very important. And then, as you all know, everybody is discussing life versus livelihood. And I do endorse that lockdown is not a solution for fighting COVID-19. And I do endorse this, that you have to have a temporary lockdown so that you can have a prepare in healthcare, prepare in strengthening your bed activity, prepare in just a public awareness program. So important thing is the lockdown in initial phase is important for a government preparedness, but for a long term, I think it will not work it out. And there is, there's a Duke University professor in recently, he has commented that permanent lockdown is never a solution for fighting this pandemic. It should be a transit lockdown followed by again a transit lockdown if it is increasing. So there are a lot of hypotheses which is coming how to do a lockdown. But yes, I don't think that the lockdown, permanent lockdown is a solution. The two important things which we are facing in India, unnecessary fear and social stigma with COVID-19. I think these two important things need to be emphasized by everybody. We have a very unnecessary fear. You cannot imagine the fear among the affluent class, because poor say we will die of hunger rather than corona, and we don't believe corona. If you go to poor, they say yes, dying of hunger or dying of COVID is equal things. But if you go to middle and higher socioeconomical status person, the unnecessary fear is tremendous. Tremendous. People are wearing N95 mask at their home 24 hours. And I always say, don't wear this mask 24 hours. It is harmful for your body. They are scrubbing their hand in home every 20 minutes. They are not going at all anybody. They are not allowing anybody to come to their house. So this unnecessary fear, I think, and social stigma. We always say we are facing problem. You are knowing that if a government has not taken a very strong action, then the doctors are being beaten. They are thrown away from the society. They are not allowed to enter into the society. No person is coming to doctor. If they say, Dr. Sahab, you are working in the hospital, so please avoid visiting my house. So this social stigma is very, very important. And the next important thing which I am going to highlight at currently, gap in care of patient of other element, especially chronic disease. If you don't treat this chronic disease, if you don't do the elective surgery, believe me, in long term, they will create an overburden in healthcare. So it is very, very important that you cannot stop treating the other disease except corona. Now, what will change? Suppose because we have to live with the coronavirus, we all know. Everybody believes that this coronavirus is not going to go away. Then we have to live with this coronavirus. What are the options? I always say the complete lockdown is not an option. And I think the government is realizing these things. They have started doing a partial lockdown where there's a number is more, you do a containment for this area. But if there is no corona in that society, I think there's no use of doing a complete lockdown. But what three important things will need to be changed in future? And I always say the healthcare practice will be changed, and it has to be changed in near future. And the most important thing, what is the approach of a physician to the patient? At present, if you see the approach of a physician to the patients, you will be amazed to see no doctor wants to see patients without proper PPE. And if I have to wear PPE, it's not possible for me to wear PPE for 6 hours, 8 hours. So now the approach to the society is entirely different. The approach to the patient will be redefined. And I don't know how to redefine it. There's a lot of debate and discussion going on how to redefine this approach. And I think near future only we can get the answer. The second important thing, yes, the approach for infrastructure need to be changed. What overcrowding we are seeing in our OPD has to be restructured, has to be reapproached, and has to be redesigned. And definitely if these all things will be done, the cost will be increased. So the government and in-pocket expense for all the medical element will be increasing, and that will be going to a common people. The most important thing which I always say, increase use of technology. Now the approach to the patient or society will be, the doctors will start increase use of technology like telemedicine, training of primary healthcare worker by remote, mobile hospitals. So these will come in the market very soon. And recently the government has given a very clear guidelines for telemedicine, and it is being legalized in this country. So there are a lot of questions and legality about teleconsultation, but at least government has started that telemedicine can be an approach at this place. Then change of government policies, that is very, very important. Because if until you change a government policy, I think it's very difficult to fight with corona for a long term. The public education and awareness for health need to be redefined. And the most important thing, approach of industry. Now we have to be internalization of pharma supply chain and make India focus is very, very important, because now recently you came across that even the paracetamol is not available more than 3 months. You have lacking lot of masks, but yes, because of encouragement of the government, encouragement of the industry, at present we are able to manufacture a lot of equipments. At present we are able to manufacture a lot of kits, PPE kits, gloves, and indigenous production of the drugs. That is very, very important. So this all need to be redefined and changed, and I think everybody is working on this. And I hope that this redefinition, because I'm not the expert of all the things, I can only raise the question to the experts that you have to redefine these things. You have to think in a long-term perspective, because we have to live with the corona.
Rakesh, you got 1 minute to go. Rakesh, you got a minute to go.
Yes, sir. I am finished. I am finished. So this everything has to be redefined. We cannot continue with our old SOPs, old policies. That is very, very clear. And everybody, there's a lot of debate. I'm not an expert of vaccination of corona, but we all believe that next 1 year we have to live. If anything comes after 1 year, it will be a grace of God, and we will be very happy. But for next 1 to 2 years, we have to live with the corona. So our SOPs, our guidelines, our approach to the society, our approach to the healthcare need to be redefined. And as early as we redefine this, we will be in the superior edge. So it has to be done not in a slow pace. It has to be done with a rapid pace, with all experts, all associations, all healthcare bodies, healthcare association to be involved, and there should be a large group discussions. And I think this is a very important webinar in which at least a lot of other people has started discussing in a forum how we have to go in future when we have to live with Corona-19. Thank you.
Thank you, Rakesh. That was a great kind of as a first speaker, you did address certain important issues. But as I said, that this talk is primarily focused towards the Indian, from the Indian perspective, in the context of COVID-19. But as we understand that the COVID-19 is basically a pandemic, and the entire world is affected, and there are a lot of demographic variation. So what may be applicable in India may not be exactly the same in other countries. So it is important for all of us being physicians and the healthcare professionals, we need to understand that how there is a demographic variation can be considered in such a situation. So is there any question to Dr. Yadav, or can we take the questions later on? Any suggestion from others? Or let us finish all the talks. Dr. Kalra. Dr. Kalra?
Yes, I'm right here.
So I think let us finish the talks and then I collect questions and have discussion. So it is your turn now. So as you know that Rakesh has covered mostly the scenario in India, but please let us know what are your perspective, your thoughts, and your reasoning of looking at the COVID-19 before it, during the lockdown period and as the lockdown is coming out, and how the patients are being treated, even the non-COVID patients are being treated, how as a healthcare professional you perceive the entire scenario from the American point of view as well as from the global point of view. All yours. Thank you.
Thank you. I'm just sharing my screen. Can you see my slides?
Yes, we can see very clearly.
Great. So firstly, thank you very much both to the Bengal Chamber of Commerce and to yourself for the gracious opportunity to speak. I am in Philadelphia at Einstein Medical Center. I'm an interventional cardiologist and also a critical care physician, and we are the epicenter of the Pennsylvania part of the pandemic here in the US. So my disclaimer is that I'm a doctor. I take care of sick patients in hospitals, and I am a frontline clinician, whatever that means, because I think all of us are fighting the battle in our own ways. But I am not a global business or planning expert. I stick to what I know, and so what I'm going to talk to you about is more my experience and what has come out of that experience, what I've learned from it, and the way I think our group is moving forward. And the last disclaimer is that I'm an optimist and a realist. I don't think that blowing up everything that we do and starting from, the days of yore is necessarily the best way to go. But I think this pandemic has exposed our inability to cope with stresses on the system. Within the financial system, you have financial stress testing, and I think that this is a societal stress test. And in some ways we have passed, but in others we have not. So this was yesterday to me. We have these are not my kids. This is a picture, but my kids are downstairs playing, in the yard by themselves. We have a yard, and the global community was normal. Kids would go out and play, and we would interact with one another in person. Close interactions were the norm, and quite frankly, I think those close in-person interactions were the source of a great deal of creativity and growth in our society, because humans are social beings. And so one of the privileges that I have is to work in a relatively niche area of interventional cardiology, where I get to go and do some physician education. So this was my travel schedule for 2020. I had lots of really nice, fun, worldwide things planned. Some of those were to visit Dr. Chakraborty in Kolkata. My wife's from there, so we were going to visit family there, and you see a lot of other places on this list. And then in late January, after I returned from Delhi, this is what was happening. And I have to admit that I had heard little bits of cases of coronavirus popping up in Seattle and then again on the West Coast, but really had no clue what that actually meant. We have a funny tendency as humans to be central in our thought, individual in our thought, and assume, rightly or wrongly, that we're pretty invincible. And so we never realized that this big red dot on this side of the world would find its way over here. But then by March 25th, this is what the world looked like. This is a picture from my television set with literally a global ticker on where cases are. And very interestingly, you'll see that on March 25th in the United States, there was 69,008 cases, and we are well over 1 million now. So it gives you an idea of how quickly this bug can spread in a privileged environment where we have the capability to self-isolate, we have the physical space, and we have hospitals to take care of us that are, for the most part, well equipped with things like ventilators, though there are certainly gaps in our coverage. And so this is my 2020 planned travel schedule as of March 26th. That's our hospital. And this is where I travel. And this is where I travel. And that's what I look like usually at the end of the day, between the ICU or the cath lab or the operating room and my office, generally with mask marks on my face. And so I ask myself often, is this actually happening? And what are we going to do about it? This is in March and coming into the middle of April. And these are the real actual numbers at our hospital where we were taking care of coronavirus patients. The individuals who are suspected is here. Those who are confirmed is here. And it's very interesting as you see this graph develop, the suspecteds go down dramatically and the confirmed go up dramatically because, and that's one of the important things that we'll talk about is because we have now the advent of rapid testing that is reasonably accurate, though certainly not 100% sensitive and specific. So this was the plan, right? This was the plan that everybody talked about. Flatten the curve. Reduce the number of infections per unit time to a manageable number so that the healthcare system can cope. This is not necessarily what people understand of this concept. What they think is that by isolating oneself or by curbing the spread of the infection within the confines of one's own life, that we're going to somehow reduce the number of infections that happen. And that's probably not true. The reality is by self-isolating, by reducing social contact, what we do is allow the system to cope and allow the system to be able to do the work that it needs to do to be able to take care of patients as they can. This, however, comes with a certain incumbency, and that is that this is a really long time. This is not a month, this is not a few months, this is more than a year. And what this then means is in order for flattening the curve to work, in order for us not to outstrip our current infrastructural resources, we as people have to be extremely aware that this is a long game. This is a marathon, not a sprint. And that as individuals, we have to manage somehow to deal with living in our homes. Otherwise, you get this, right? Which is a finite start and stop to the infection. And that's largely with, you know, what Dr. Yadav was talking about a few minutes ago. This is largely what some of those people may be thinking who are living hand to mouth and realize that they may end up here, but if they're lucky, they'll end up here somewhere. And the 70% herd immunity that's necessary to prevent global infective spread will have been developed. So yes, many will die, but some will not, and most will continue to live reasonably normal lives within a foreseeable period of time. And so this is our problem. These are the types of things that I'm seeing on a day-to-day basis. Don't cancel my golf season. I need a haircut. This lady seems to think that massage is essential. She obviously has not been outside of her bubble for very long. And this guy, I can understand to a degree. He says, let's get our teeth cleaned, but thankfully at least he's wearing a mask. And so we deal with people who have very disparate understandings of the problem. This is a reflection of how they live in their own microcosm, right? What's around them and what they see. I wager that none of these people has ever come into an ICU in a coronavirus affected area, certainly never come up to rounds with me and seen the various people that I have to manage on a day-to-day basis. And I also wager that they probably don't have very many people in their local geographic area that have been affected by the virus. And so they don't really understand what it is. And so it's incumbent upon us then for individuals to understand that shutdown is indeed a necessary piece of the puzzle, but just as Dr. Yadav pointed out, it is not a solution. It is a mechanism through which the system can cope. And so when we explain that, then we also have to explain that the system can evolve and the resources can evolve so that the shutdown, though in effect, is not a permanent measure or not even a long-term measure. It is a measure that allows us to catch up quickly enough to deal with the onslaught that's coming. So this is what Texas looks like right now. Okay, they had their single largest growth in cases in one day, 1,860, 2 days ago. And then I think the animation is not working here properly, but the picture that's in behind this graph is a big motto from the state of Texas that says we're back in business. And they have fully opened the state, despite rising numbers of cases, with rising numbers of new cases. This, as a physician, and as I'm sure as a reasonable human being who understands what they're looking at, is bananas. It's out of their minds. But it's, I think, a perilous view to take to assume that the people that one speaks to or one interacts with are foolish. What is probably more likely is that they are acting rationally based on the set of facts that they have. And therein lies the fundamental problem. People need to get the facts. So we need to adapt to a new world with this virus that is going to continue to be here for a period of time. But as healthcare leaders, as business leaders, as administrative leaders, we also need to recognize that humans are social creatures, and that social interaction forms the basis of what we do every day, and that it's not palatable or even possible to stay away from loved ones in their times of need. And most importantly, and this is probably most germane in a place like India, we are dependent on one another for one another's survival, not just through the social interactions and the resources that we give one another, but because if we carry an infection, it is incumbent upon us to be careful not to try to pass it to another. Just as for others, it is incumbent on them to understand that not everybody carries an infection, and that if we are able to interact with one another in a modified fashion, in a careful fashion, that we can continue as social beings. So these are what I see as the upcoming major challenges. This has resulted on a severe toll on healthcare workers and related infrastructure, including staff burnout and, quite frankly, PTSD. These are colleagues that are wearing garbage bags, true blue garbage bags, things that they pulled out of their kitchens to be able to go and see their patients. And so I do not, certainly on this side of the world, agree with the supposition that doctors don't want to see their patients. I think very much the opposite here, where we recognize that when a building burns, the fire department runs in and they put out the fire, putting their lives at risk. And today, this is our bag. We carry this one. This is our job, and we will do it. That being said, I think it's also reasonable to understand that when a firefighter runs into a burning building or a police officer runs into an area of violence, they're protected with a bulletproof vest and a gun. And we as healthcare providers need to have that. We also need to have a healthcare system that's able to supply those things, and those who are not able to supply immediately, we have to develop ways of dealing with that. Our hospital ran out of PPE. And one of my fellows, who I'm very proud of, she's an interventional fellow, she's very innovative. She found a 3D printer, and she started printing face shields out of PLA. Then she printed masks, where we can take one N95 mask, cut 6 filters out of the single filter in front of it, build it into her reusable mask that can be re-sterilized, and she has supplied the whole hospital. Then she went and got nylon and sewed gowns, and we have developed a mass production method to be able to handle that on our local level, so that we don't have to deal with things like this. This looks like a satellite image, but if you look at this, this is a trench, and this was a trench dug on an island just outside New York City for mass graves, for all of those people that are unable to receive the care that they need, or unfortunately have died of this virus and don't have anybody to claim them from family. The other important thing is there is a degree of diminished trust in the globalized world. Where did this virus come from? China, the US, a lab, somewhere in India, somewhere in Singapore, somewhere else. And so as a result, there is a fundamental distrust in the interactions that we usually have that carry us forward, that we took for granted every day. As a result, travel is slow to recover, and focus on productivity is now secondary to focus on survival. And the concentration has shifted from global to local. Obviously, this comes with inherent challenges in a world where we depend so much on one another. And then privacy, something that's particularly important here in the United States, and individuality becomes a challenge, because places like South Korea, who have very effectively fought the spread of this virus, are doing so by using CCTV cameras and by using phones and by using geolocal tracking to be able to notify people when they have been affected. So what's the way forward? Well, in echoing Dr. Yadav's comments, a uniform collaborative healthcare infrastructure where fundamental changes occur are necessary. Investment, yes, that means money from central bodies. That means the government that cannot continue to spend 1% of their GDP on healthcare. If that means sacrificing some of the luxurious infrastructures, then so be it. But money needs to go into the system so that things like PPE as well as healthcare resources can be beefed up to be able to deal with the long game, right? We're not talking the forever game. We're just talking for now. Because if you have no people that are healthy left, and make no mistake, when you're treated with coronavirus and you recover, you do not return back to normal. for the first many weeks, or so is our experience. Unless you invest in that kind of infrastructure, you have a populace that isn't able to contribute as well as they used to be. On our end, we have regular administrative calls between the chief medical officers of hospitals across the city and the region so that we can load balance, so no hospital is overburdened. There's an emergence of central resource allocation of critical resources for PPE, so that if we're doing cases, elective cases that can wait and can be managed on medical therapy, our PPE is taken and it is redistributed to places that are dealing with emergencies only. And then there's regionalization of critical services on a local or nuclear level, so that we're parsed out within our communities, and each of our communities have a go-to hospital to go. And most importantly for patients, there is very open communication. And this is something that I have noticed going to India on a frequent basis. There seems to be a fundamental lack of trust in the medical system. I don't know if this is because of a patient pay system, because as patients, individuals feel a little bit like they're taking their car to a mechanic where the doctor just says, this is what's wrong with you and this is what you need to get fixed. But what they hear is, this is what it's going to cost you. There seems to be that erosion of trust with violence against physicians and violence against the healthcare system. And that needs to be restored. A focus of that needs to be restored, so that, just as Dr. Yadav pointed out, when people hear things, they trust the information they get from reliable sources. It'll stop the misinformation that spreads. We need to grow digital interaction platforms to facilitate distance, but allow interaction. The majority of my outpatient visits are now televisit. There are protocolized criteria that we have built to bring patients into clinic where a smaller but appropriate amount of PPE is available so that we can see them. And then there are very, very interesting, very new and very intelligent technologies that are coming out that we are now leveraging. Ways to listen to hearts over telemedicine, ways to monitor ECGs through an iWatch. These kinds of investments are necessary and are possible. Make no mistake, they're possible in countries like India, where the tech sector dwarfs our own here in the US. I think that the brain power that you have across the South Asian subcontinent it's incredible. And finally, we as a group have to recognize the growth opportunity. We need to accelerate our data analysis. We need to understand and invent solutions to some of these problems. Recognize when things don't work, and then come back and restart and report. And most importantly, the messaging to society has to be clear. Well, this is a problem. It's real. Social distancing is the only way for us to cope for now, but we are working to fix this. Here's what we have to work on. This worked, this didn't work. And know that we're working hard. Here's what we're investing in you. These are the messages that need to get out to the patient populace and the large body of individuals across the country who don't necessarily communicate through TV and email and internet and WhatsApp, but instead on the ground and through word of mouth. That means outreach. And that's where a large part of the money has to be spent. So people are aware and informed. So eventually this can become this. You'll see that this is, the date on the right side of the screen is 5/22. And this is what our volumes have done. This is a beatable disease. We can get there. It will take time. And so for the foreseeable future, Corona will be around. And it's up to us to continue living as people, continuing to interact as individuals, depending on one another and helping one another, sort of clean hands, open hearts, if you will, so that we can continue to beat this disease as a global community, as opposed to as individuals, but recognize that in that global fight will come a lot of individual and a lot of local community resilience that will have to be built so that it can be joined community by community to be able to provide solutions. Ultimately, life as we remember it will eventually return to normal, but not soon. And so this is an opportunity for us to focus on infrastructure and the way forward so that we can continue to grow. Always keep in mind that it is not good enough to survive. We must thrive. Thanks very much.
Great presentation from Dr. Kalra from Philadelphia. I'm sure that you raised a lot of issues. I think the point what I like personally, the stress test. We do, cardiologists do cardiological stress test, but now I think we are doing social stress test, maybe mental stress test, financial stress test, fiscal stress test, and the community is undergoing so many tests accompanied with the stress. And we need to, and the last point is very nice, that we're just not going to survive. We need to thrive keeping COVID-19 around. You also talked about that there is severe toll. Yes, I mean, as we can see in the whole world, there is more than the 5.3 million people are affected, and about more than 350,000 people died for no obvious reason. Just a kind of a tiny virus from nowhere came and killed 350,000 people, which is not acceptable to a civilized community like ourselves. You also talked about the trust and restoration of trust and distrust. I think we need to connect all the time, and we need to understand. I think there are a lot of misunderstanding going on. There are many factors that are playing around for this misunderstanding, and privacy of the people are getting affected. And when you talked about COVID-19 virus, taking the virus from the United States to China, to India, to some other country, we're actually deviating the focus of our priority to treat our people. Because as a physician, I think every single human being, when he or she is ill, deserves to become well. That is the kind of commitment that we, the physician, have to the community. And if that focus is being taken away from one country to another country, the commitment of physician, commitment of healthcare professionals deviates, and that is not acceptable to any healthcare professional, whatever may be the country of origin. That is the way I personally feel.
I think you bring up a very important point that I think we need to flush out for a second. We as physicians take an oath, right? We commit ourselves to patient care, but the system in which we work is not run individually by physicians. It is interconnected. And that's why I say, I don't think it makes sense to blow up the whole system and start again. It makes sense to create infrastructure on a local level that integrates all of these things, right? So if you have a local system where your healthcare system is being run by a set of local administrators, those individuals need to be very honest and very open with the people that they're working with. And most fundamentally, you all have to have the same goal on day one. One of the, I credit where credit is due. My current chair, who is an electrophysiologist, he took over the chair of our division of cardiology, under difficult circumstances a year ago. And he's not a whole lot older than me, but the man is a visionary leader. And one of the things that he did most effectively is communicate. We get update calls amongst all of the individuals in our division every single week, sometimes twice a week. There's an email that he sends out every 2 days with an update on all of the numbers that are in the hospital, what we're doing about PPE, who's sick, who's not, what we can do, these kinds of things. That open communication, the transparency is the basis, the fundamental basis of establishing trust so that everybody is on the same page. Now, India is challenged because when you have a true democracy and everybody wants to be involved, it's very challenging to have everybody involved when there are so many people. And so within that, there needs to be an understanding with that honesty that everybody's voice can be heard, not everybody's opinion can be catered to, but that the message, the individual desire, the fundamental purpose is still the same for everybody, right? And that is that we all want everybody well to survive and to thrive. That way mistakes are not so bad.
Right, I think there's some comment came which is very nice, that Dr. Kalra actually has hit the nail on the head, which is right. We'll come back to that. But prior to that, just before I take Dr. Nandi on board, one quick thing I must mention at this point. You did mention about herd immunity. What is that herd? Herd changes. So like your herd is not the same. Is your United States herd is not the same herd of let's say the UK, or not the same herd of India. For example, in some countries may believe that I'm going to remove people above 75 years entirely and create a new herd, create a new immunity. A. B. So what is the herd immunity in India may not be the same herd applicable to a country in Africa, for example. We need to talk about it more in detail. I could quickly touch on that.
I'm not a clinical, virologist, nor am I an immunologist. But the concept of herd immunity is when you have random spread of a factor, and there is 60 to 70% of individuals who are unable to be affected by that factor, that constitutes herd immunity. And if we're all people and the virus infects people, then whether it's a herd in the US or a herd in India, the herd is the herd, right? It's worldwide, but but the development and the speed with which immunity develops, that is locally dependent, right? So wherein we in the United States have taken social distancing in some areas to heart, and people have been in their homes for weeks, herd immunity is actually developing very slowly, but in those areas, infection rates are going down. We recognize that eventually we will develop 70% of people who are immune, and that will allow us to save lives, not just because you infect less people per se, but it's because the resources to treat those people become available when they get infected, right? The number of infections happens.
Right. I think we move to Dr. Nandi. And Dr. Nandi, you are going to talk to us about the recalibration of the society, the financial aspect of the healthcare, and even the healthcare itself. So Dr. Nandi, all yours. I believe he doesn't have any slide, but he's going to talk to us from his experience and from his day-to-day sort of, the way he's handling the healthcare scenario, particularly the insurance sector in the United States. Dr. Nandi?
Good evening to everyone in India. First of all, this whole thing has been very enlightening for me. I thank Professor Yadav from the All India Institute of Medical Sciences for giving such a clear-cut vision and a very pragmatic vision, which is so much needed in the United States currently about how to deal with this COVID virus. It was truly enlightening, and I started remembering my class days in AIIMS when we had Professor Sujoy Bijoy Roy as the chairman of cardiology at AIIMS. Dr. Kalra's speech had a different perspective, and I enjoyed it too. I would like to say that myself, from my own experience, and I am a psychiatrist and run a telemedicine company in the United States and provide telepsychiatric consults to over 800 rural nursing homes in the United States. And I've been doing this for the last 5 years. So this is not something new. We have been bringing telepsychiatry and rheumatology and immunological services in rural nursing homes in the United States and have excelled in that. We also provide revenue cycle management to nursing homes and hospitals. And we have seen the crushing blow, the finances of the hospitals in the last 30 to 45 days. In the United States, where we have a healthcare budget of almost $3 trillion, the United States has had increased the funding of Medicare and has advanced a lot of money to hospitals and nursing homes appropriately for them to thrive and for them to survive. So I will start by saying that all healthcare institutions in India should forget about profit this year. For this next 1 to 2 years, till we have this coronavirus menace disappear, forget the profit, but become totally aware of the loss. This is the time when hospitals, healthcare facilities can think about branding. How do you think about branding? And that is an intangible asset which would be of immense asset by providing the most empathic services to every patient that comes to your door. This is the time you collect money. You collect your money not by actual currency, but by branding and getting ready for the future. I'm also an eternal optimist, so I would like every hospital to collaborate with each other, because we have to remember that united we would stand and divided we fall. Institutions can build a lot of trust back with the patients if they forget the profit motto and think about achieving targets by providing the best quality treatment. What do I mean by best quality treatment? By spending adequate amount of money for PPEs, for spending adequate amount of money to provide whatever is the optimal care that patients need. And we have been seeing that the level of care varies from institution to institution depending upon their finances, depending upon their institution. So one has to proactively think how one can fund themselves and not be able to shortchange the patient. This is definitely a call for all politicians, local politicians, because this is finally taken care locally. I myself, born and raised in Andaman Nicobar Islands, and I've been interacting with a couple of doctors from Andaman how things in Port Blair are, and to your surprise, you will be totally surprised how optimal care is being provided at the GB Pant Hospital in Port Blair, where they right now have over 500 patients, but they have been able to contact, trace every patient, isolate every patient in their home, being able to provide the best possible care, and only the patients that needed absolute hospitalizations were isolated in the GB Pant Hospital and provided the care, with no patient having died till now in Port Blair. I was totally amazed by this level of care. So this does not require rocket scientist thinking, but more empathic understanding of the patient and to go the extra mile. And my such interaction has totally surprised me. And publishing such anecdotal cases, even in the local newspapers, only moralizes for another physician, maybe in Lakshadweep Island, to take up the challenge and be able to provide that optimal care. So the newspaper, the media has a very strong role in terms of publishing these success stories, which we see in different parts of the country, throughout the country. And such oasis and such care, when delivered appropriately by appropriate public health screening and public health epidemiological rules, and following those will only help to brand, optimize, and will allow people to take more risk and not make patients get themselves locked up. Right now, there is this, like Professor Yadav so appropriately said, that there has been such a social stigma against doctors, nurses, and this is because just lack of education. And we have found out that even residents who were renting houses in these exclusive neighborhoods of New Delhi, close to the All India Institute, were evicted by the landlords, which just goes to show that even with all the wealth living in the most expensive zip code, just because of their lack of education, and did such horrible things against physicians who are trying to do the most noble jobs and are the hero, and I dare say are equal to the army officers who are saving our borders in the front. So again, I come back, this is a unique time to brand yourself, for facilities to brand yourself. You will rip millions of dollars in profit down the line if you brand yourself as the place where there was empathic, optimal care. And it has to be that no patient was denied care. Yes, there is expense in buying PPEs and all that, but appropriate, adequate planning, isolating places for these patients, providing care to these patients, and not kicking these patients out are the most important steps that one will take. It is also equally important that we do not forget about the elective surgeries that needs to be done. These elective surgeries or elective procedures that needs to be done. Patients who need to have a stent on needs to get their stent, otherwise they will end up with myocardial infarction. And it is very important and cognizant that we do not work in an all or none phenomena, and that time is gone. We had the social distancing for 2 months. It is now time to take risks, and appropriate calculated risk, so that the institution thrives, so that the patients thrive, and we move forward as a society with a lot of hope in our heart. Thank you again for providing this opportunity to me. Thank you very much.
Thank you, Dr. Really, really wonderful. We have some question. We'll take it up later on. And meanwhile, you really did talk about non-COVID patients care, which Dr. Kalra also mentioned, which is essentially important for all of us to recognize that during COVID pandemic, we must not forget the non-COVID patients. Even Dr. Yadav also raised that point, because if you do so, then the burden of healthcare will profoundly increase. And your experience at Andaman is also excellent. We will share that. We'll take some more feedback from you later on once we finish all the faculty's presentation. May I now invite Dr. Anindita Chakraborty, the youngest of the entire faculty, to share your experience of how you foresee the healthcare coming out in next 25 years time, because today is COVID-19 and later on, what are your thoughts? If you could share your thoughts with all of us. Dr. Anindita Chakraborty.
Yes, of course. I mean, I don't know if I'm that young. I'm pretty old, actually. I'm on the older side, but I'm younger than a lot of you. So I'm not really, I don't know if I understood my topic, because I'm going to talk more about what I have seen myself in my training. I'm still a trainee. I think I'm the only one who's still a trainee. And then if there are other things that come up, then I'll just talk about it. So let me just pull up my slides. Hold on. Okay, so like I said, my name is Anindita Chakraborty. So I'm essentially a child psychiatry fellow in training in Detroit, Michigan. So just, I don't know how many of you know where Michigan is, but hold on. Can I not get this to move? Yeah, this is Michigan in the United States. It's up here. And can you see this glove-shaped state? So I live down here in Detroit. So I'm saying that to you because in my state, Governor Whitmer, the governor of the state, she declared an emergency. It was back in March 10th. And we have been one of the hard-hit areas in the country. Today, I think we have 55,000, almost 55,000 patients with confirmed COVID, if not a little less. Things were really, really bad when things started out. As a child psychiatry fellow, I'd volunteered and I'd put my name on the list, and we were all going to be redeployed, but then it didn't happen. I don't know if that was a good thing or a bad thing, because my colleagues had to go through what they went through. The things were really bad. The ICUs were just, I mean, there was no room. There were just COVID hospitals everywhere. In my training, all of our clinical care shifted to telepsych or video consultations. I think it wasn't until yesterday, which is when our clinic has started back up. I mean, it's almost been 6 weeks, if not more, since I've seen a patient face to face. So all my clinical care has been online. I want to be very open about this. I wanted to participate in this discussion because I wanted to learn more about what everyone else has been going through. I don't have any data or guidelines. I just have anecdotes. I want to talk to you about what I've seen my families go through during this time. So for me, it's really more about learning about what your families have been going through. So we know that, you know, in order for kids to develop normally, in order to have normal childhood development, you have to kind of have basic things like sleep and school, family, social connections, physical activities. Everything is gone. There's been chaos in a lot of my families. My kids aren't sleeping. They're always on their device. My teens are on social media nonstop. I'd be curious to learn about what you're doing with your teenagers, making sure that they're safe. I had a patient the other day, for instance. She's a very secretive patient. and her social media use has gone up exponentially, and her mom has been finding out that she's been posting things about herself online that are inappropriate. And then I talked to my patient later on, and she's telling me she's feeling really lonely in COVID. She's resorting to these things. And teens don't make any sense, but it's just an interesting challenge that came up. My kids I have a kid with OCD. His symptoms have just hit the roof. And it's really hard to do a CBT or cognitive behavioral therapy with patients who have real anxiety. I mean, anxiety that is legitimate in the face of COVID. What do you say to that kid? You know, so that was a challenge. With families locked in together, there's been a lot of conflict. I take care of patients in Detroit, as well as sort of towns around Detroit. A big part of the population in Detroit is below national average income. They're often from families that are abused, not abusive, a lot of substance use, and now they're kind of locked down with each other. A patient of mine, she has started sleeping during the day. That's her way of staying away from her dad, because he has to do things around the house during the day, because that's her way of avoiding him, because she can't run away. In Michigan, and I believe it's the same for the rest of the US as well, all schools are closed. So kids are not going to be in school for almost March, April, May, June, July, August, September, 6 months. Schools open back up in September, and everyone's using Google Classrooms. I don't know if they use that in India, but it's essentially online school, and that's been a big adjustment. Working parents are saying that they're working even harder when they're working from home, because they're doing their regular work at home, and they're taking care of their kids, and kids want attention all the time. So it's been very stressful, is what I'm getting at. I don't have any guidelines. This is, again, hold on. What I attempt to do more than anything is I first try to get a sense of, and I'm curious about what you do. I talk to my patient and I get a sense of what's going on with them, but I always make sure that the family's on the same page. I've been surprised to find that sometimes parents see the pandemic very differently and kids view it differently. I find that kids are very responsible compared to their parents. They're more stringent when it comes to social distancing. I try to make sure that we all understand it in the same way, we speak about it in the same language, and that we're able to sort of regulate ourselves appropriately. Although that's hard, because it's a real fear. How do you dispute something when it's real? I think the biggest lesson for me has been kind of, we're talking about managing anxiety, depression, conflict at home, is maintaining routine and limit setting. And we can talk more about the meaning of limit setting and what that means in the discussion. But that has helped families a lot, kind of create this safe space between each other, and talk about what's negotiable and what's not. But yeah, I'm interested in what everyone else has to say. I know that, I think earlier on, Dr. Chakraborty asked me, earlier in the meeting, he asked me, what do I think is going to happen in 25 years? And I said, I don't know if we're going to make it, the human race. It sounded very pessimistic. I didn't mean that. I am actually quite optimistic. I think that having worked with families in the pandemic, despite everything, it has created a sense of cohesion. And I think that only good things will come out of it. That's it.
Okay, thank you very much. So that was a kind of a broad overview of Dr. Anindita Chakraborty about COVID-19 around, and we have to survive and to thrive. And can we move to the next one, Dr. Angela Hoy from the United Kingdom? Dr. Angela, if you could come up and talk to us about your feeling about COVID-19 and our life keeping COVID-19 around. Angela, all yours.
Sure, thank you, Rabin, and many thanks for the invitation. It's a great pleasure to be part of this. Let me just check that you can you see my screen?
Yeah, we can see it clearly.
Great. Okay, so I'm going to talk a little bit about the healthcare system going forwards, really. Obviously, my background is working as a cardiologist in the UK, so some of my opinions are very much related to our experience and when we're at, the situation that we're currently in the UK. So these are the graphs that we're all starting to become very familiar with. Unfortunately, the UK has had really quite a high number of deaths from COVID-19. We're counting both our hospital deaths as well as quite a lot of deaths in the care home community. So we are one of the top 5 countries around the world that have had a significant death rate. We're in orange, and the good news is we're coming down. So we have reached our peak and we're now on the decline. And what that has meant is that we are now starting to come out of lockdown and start to resume more normal activities. But it's most definitely a phased response. We can't just go back to how things were. So, okay, I can't go forwards. There we go. Right. So alongside that, you can also see that our percentage of critical care beds occupied by COVID-19 patients has also fallen, and it's become much more manageable. When COVID-19 first hit, we dramatically increased our ICU capacity to the extent where we built several new hospitals. So we put intensive care facilities into very big buildings that were essentially previously used for delivering conferences. Fortunately, they weren't in the main needed to be used, but we're now down to around about 30% of our intensive care beds being used by COVID patients, and that means we can start to think about opening up that opening up those beds to be able to be used for instance, our high-risk surgical patients that up until now have not been able to have their bypass graft surgery or their valve replacement surgery because we haven't had the intensive care capacity to be able to look after them in a safe manner. So important principles, I think I'm just going to reiterate what everybody else has said really. This is not a short-term crisis. This is something that's going to go on for several months. There's no easy or quick solution. We don't have effective drug treatment. I know there's obviously lots of trials ongoing, but none of them have really provided us with a magic cure. And there's currently no vaccine, although you may be aware that in the UK, we have just started a very large study of a vaccine that has been produced in Oxford, and it's being rolled out to many thousands of individuals, including healthcare workers, and that's going to start recruitment as of Monday. So in 2 days' time, we're going to have the start of a very large vaccine trial. It's really important that we keep the COVID-19 transmission rate under control. We've seen this sort of information about what happens if you don't endorse social isolation. You get one person who's infected who transmits the virus to 2.5 people, and after 1 month, that means more than 400 people have been infected. So it's really important that anyone who is infected with the virus is isolating and is not transmitting it to others. Principles, of course, we know hand washing, we know it's important to maintain social distancing. And this is the real challenge, because as we start to go back to normality, what we really want is to ensure we can try to maintain a degree of social distancing on things like public transport, on things like the workplace. And certainly in the UK, what the advice has been is that although wherever possible, it's advised to continue to work from home, if you do have to go to work, employers are being asked to try to make adjustments in the workplace. So that might mean that instead of everybody arriving at 9 a.m. and then everybody leaving at 5 p.m., there's a very graduated, so there's different people arriving for work at different times of the day. The shift patterns are very fluid, and you try to maintain at all times people still working in isolation, in other words, 2 meters away from their colleagues wherever possible. And if they do have to come into close contact, you try and maintain small bubbles of small teams that have close contact, but they don't then work with other people in other bubbles. And we avoid things like hot desking. So in the old days where you used to hot desk and share facilities, we try and avoid that. Of course, the working from home needs reliable technology, and that really needs, I think this is a real impetus for us now globally to ensure that we really roll out technology to everybody. It needs to be made available and affordable across the board. And of course, we need to maintain the situation of self-isolation for anybody who has any symptoms at all. And that will remain the case long term. So the effects of COVID-19, there's an effect of health. So obviously there is a mortality rate from the disease itself, but the thing that is becoming really apparent is the mortality that can potentially occur because of other illnesses. So we saw data from Italy that showed that the out-of-hospital cardiac arrest rate went up dramatically because people did not call for help because they were worried about the COVID-19 situation. As well as that, of course, we have patients potentially at home who have cancer, who are not getting the treatment that they should be getting because of COVID-19. And we need to start focusing a little bit more on those patients that we really need to expedite their treatment, whilst of course continuing to offer the care for the patients with COVID-19. We've seen the effect on the economy. It's become catastrophic for many businesses that are really unable to operate at all. And that, of course, has an effect on the economy. It increases the unemployment rate and the poverty levels. So it is important that we start to open up our businesses and our economy once again, but we will probably have to be quite innovative in the way in which we do that. And of course, the effects are also social. We've heard very nicely about how it affects children and young people, and certainly effect on education. Yes, you can homeschool, but I think a very important part of your childhood is to be educated in the social interaction with your peers. And certainly both of my children are missing the ability to just go out and play with their friends. Effect on mental well-being, we've seen people that have become extremely anxious, washing their hands all the time, very anxious that they're going to catch this virus, and that if they do catch it, they're going to die. We've also seen problems with healthcare workers becoming burnt out. It is challenging to work some of these very long shifts. It can be quite distressing. And so I think we need to make sure that we look after society, but we also make sure that we look after our colleagues. So the principles of the healthcare really are first and foremost to protect the workforce. And that certainly involves PPE. It also involves support and mental well-being. We need to protect the most vulnerable people in our society to try to reduce the risk of them catching COVID-19. Of course, we need to continue to deliver healthcare to our COVID-19 patients. And I would urge wherever possible that when we're offering some of these treatments, we try to participate in clinical trials so that we are collecting data, because it's only by collecting the data that we will then have the evidence on which to subsequently try to manage subsequent patients who have this disease. And of course, now we need to try and think about treating patients who have other illnesses whilst keeping them safe. We have certainly had a few patients that have come into my hospital who have contracted COVID-19 whilst on the ward and who have died. And we need to try and avoid that. So what do we do in the UK? Well, we assume that all patients are COVID-19 positive. So this is all the acute admissions, the unselected admissions. We assume they are all positive until proven otherwise. And so it is the norm for standard PPE to be worn throughout the hospital. It has to be put on whenever you enter a clinical area, and it has to be removed when you exit the clinical area. You shouldn't be walking around wearing your gloves and everything and potentially then infecting surfaces. We know that the virus can remain viable on surfaces, on steel, on cardboard. So you don't want to be touching anything with your gloves on and then going and touching other surfaces. So if you have any sort of interaction with anybody, if you touch a patient, then you remove your PPE, wash, and then you re-don another set of PPE before you go and touch another patient. Now, this is obviously means that we get through quite a lot of PPE, but in a similar way, actually, we've been quite innovative in the UK. You'll find that a lot of the UK had problems with PPE, and in fact, in some areas, there's still problems with PPE. Our university shut to students when we went into lockdown, and so we've been lucky that we've had a university department use their 3D printer to produce visors, etc. for us. So we have gone out to our local organisations who have been a great help. So we now have visors and glasses everywhere. We have a lot of PPE. The UK government employed the army, and so the operations strategic planning part of the army organised PPE delivery across the whole of the UK. Because another thing that we found was that hospitals were not too bad. We were already requesting PPE, but places like primary care physicians, care homes who wanted to protect their residents, they found it extremely difficult to get hold of any PPE at all. So the government and the army coordinated the delivery of PPE and continues to coordinate delivery of PPE across the whole of the country. So the more extensive PPE, so this is the high level of PPE, we keep very much for critical care patients and also patients who we think are at significant risk of cardiac arrest. So that will include our heart attack patients going into the cath lab. But the majority of the time, we're wearing the slightly lower grade, if you like, standard PPE. Obviously, if somebody goes into cardiac arrest, then we upgrade our PPE before we start resuscitation. So we need to have widespread availability of PPE throughout the hospital in all areas and for all members of staff. So the next thing is to protect the most vulnerable people. And I think that when we start to open up our countries, our services, I think we still need to be very much aware that there are certain individuals that are at increased risk. And so again, in the UK, we've got some data of the sort of first series of hospitalized patients. It's quite a large series, I guess. It's 16,749 patients who were hospitalized. And we can see findings that are very consistent with the data that had previously come out of China, albeit on slightly smaller numbers. So then we know that the death rate is very much related to age, particularly if you're above the age of 70. It's worse if you're a male, and it's worse if you have other diseases, including cardiac disease, lung disease, kidney disease, malignancy, and also, interestingly, obesity and dementia. So we have advised patients in those categories to remain in self-isolation. So although many of the younger workers have gone back to work, these high-risk individuals were all sent a letter from the government. They were contacted by their physician, and they have been told to maintain their isolation until the infection levels have dropped further. So if we focus a little bit now on other patients, because this is now our real challenge, and this is what we're starting to try to deal with in the UK. If we look first of all at acute services, as I've already mentioned, we assume that all patients are COVID positive. And so I think you have to be very clear in your mind that you can be completely asymptomatic with COVID-19, and you can also have a negative swab despite actually having the illness. And so we admit patients assuming they have the disease. We ask them to wear a surgical mask if that is feasible, and particularly if patients are moving from the emergency room into different parts of the hospital, we try to keep a surgical mask on them to reduce the risk of viral spread. And we divide our hospital into 3 zones. So we have the red zone, which are patients confirmed to be COVID positive. We have an orange zone where we have yet to determine the status of the patient. And then we have a green zone where we are very sure, very clear that the patient does not have COVID-19. And it's really important to try to segregate the accordingly, so that you can divide the patients or manage the patients, and you don't mix the patients up, because otherwise you will get spread of the virus whilst in hospital. So what have we done with our elective services? So it's really important to determine that these patients are COVID-19 negative. And what we've done is we've reintroduced our elective services on a phased basis. So we've done it based on clinical urgency, and all of the doctors across the hospital have been asked to look at their waiting lists for people that are on the waiting list for procedures, and determined whether they are very urgent or whether they can wait just a few more weeks until we get ourselves back up and running, and our viral transmission rates or infection rates within the community have further dropped. So people needing cancer surgery, people who need procedures such as implantation of a defibrillator are getting prioritised. People with stable disease, so those waiting for, say, a hip replacement operation, or they have chronic stable angina that's pretty well controlled on medical therapy, well, they're going to wait. And so what we do in practice, we have a dedicated ward whereby we admit these patients. So we will not have any interaction between acute patients and these elective patients. They are put in a separate ward completely. They're fully screened, both history and also the swabs. And our cardiothoracic surgeons are doing routine CT thorax scans a few days prior to the cardiac surgery, just to make sure that the lung fields are clean. It's really important that the ward is kept very clean, and obviously you can see that our cleaner is also wearing PPE. That's really important. All of the staff on the ward maintain a low level of PPE, and we have we have tried to enforce that staff do not move from an acute area into an elective area during the same shift. So our red zone is very separate from our green zone. I think one thing that is currently being thought about is whether staff members also need to be regularly tested. I think testing is absolutely key to the ability to be able to get on top of this. I mean, we heard about the experience of South Korea, where they did a lot of testing and they've really been able to contain the viral transmission very effectively. And it may well be that we need to undertake regular spot testing of staff members, as well as obviously patients. We certainly, again, in my department, have had several staff members with absolutely no symptoms who have subsequently tested as positive. We also ask that no visitors come to the hospital at all onto the green zones, so onto the elective wards, because we worry that they may inadvertently introduce the virus. So my conclusions really is that this is not a short-term situation. We need technology. I think that we have learned that we can work really quite well using technologies such as Zoom to have meetings. We're also trying to ensure that we have lots of discussion with relatives, and indeed our patient consultations are often done remotely, and that actually works easier than I thought it was going to in the majority of cases. I think we need to make sure that we have enough critical care capacity. And I think one thing that became very clear in the UK is that we, prior to this pandemic, did not have enough critical care capacity. And so when the pandemic hit, we were really struggling. And we had orthopedic surgeons, we had cardiac surgeons all looking after critical care patients because they were no longer undertaking any surgery. We need to make sure we've got enough staffing. We need to support our staff members to make sure that they remain well and they're not suffering from burnout. We've heard about PPE a lot today, and I think that that is absolutely vital, because we can transmit the virus just as easily as we can also catch the virus. And that is not just us. I mean, I put there the workforce, but actually that may well need to also be considered in the workplace. We need to think very much for individual businesses, whether they can maintain social distancing, or whether actually we need to also recommend that PPE be used out in the workforce. We need to continue with high standards of cleaning across our hospital departments, and we need to make sure that we have lots of hand washing facilities available, so that wherever we're donning and doffing our PPE, we maintain good hygiene. As I said earlier, testing is absolutely vital, because if we don't test, then we don't know how much of a problem we have in our local area, because the reintroduction of doing elective work will very much be dependent on which part of the country you're in and how much of the population is affected by the virus. And I think one thing we should aspire to is to try to separate our COVID-19 positive patients from those without COVID-19. And so we may need to think about reconfiguring our services to try to keep acute admissions away from elective patients. And that's certainly something we're doing locally where I work. We're lucky enough to, or maybe sometimes it's a disadvantage, but we work on 2 different hospital sites, so 1 trust, but 2 hospital sites. And we very much have a hot site and a cold site. So we try not to combine the 2. So thank you.
So it's a great overview of the scenario. You started with your experience in the United Kingdom, in your hospital, in your country, and then moved out from your country to the global level, and touching upon all the essential points. So we started a little late, so maybe we have got another 5 or 10 minutes time to have some quick questions. So I will ask maybe 2 questions for each faculty. To start with Dr. Yadav, Dr. Rakesh Yadav. But before that, Angela, the quick question to you from one of our audience is, what is the current status? What is the current status of Oxford University vaccine?
Yes, so they have done some first-in-man safety tests, and that has passed. So they've completed their phase 1 trial, and they are undertaking a big trial. As I said, it's going to start on Monday, and they're looking for over 1,000. Is it 1,000 or is it 10,000? I should know that, and I can't remember. But it's a large study, and they're looking to vaccinate particularly healthcare workers, particularly children, particularly elderly, so at risk, vulnerable people, to see whether it potentially is effective. But it's not the trial that's going to provide the answer. It's just the next step in the data gathering to see whether or not it's going to have any benefit. But so far it's completed phase 1, it's going into phase 2.
How much time roughly it is going to take? Roughly,
yeah,
a year, 2 years?
It's a good question. The call for volunteers went out last week, and I think they've already got a sort of oversubscription of people that have wanted to participate. And so I think the actual recruitment will happen very quickly. I think pretty much every hospital is recruiting healthcare workers, and as well as that, there's around the Oxford area, a lot of people also putting their hands forward and volunteering to receive the vaccine.
Great. Dr. Rakesh Yadav, there are 2 questions to you. One is, do you think hard immunity will work in India, having a population of 138 million? Do you think that we may lose 10% of our population if we try to impose hard immunity in our country? Dr. Yadav.
What in a recent past we have seen, all mathematical calculation regarding COVID has failed. So this virus is a very peculiar virus. Even the UK has came that we should have a herd immunity. And my relative who are staying in UK, if you have a common cold, nobody is testing. They say you presume you are a COVID patient. So it is very difficult to comment upon that India will have a herd immunity, because for herd immunity, at least you have to be more than 50% population who is infected. So, and the mutation of virus, the virus has already more than 30 mutations. So the mutation of virus is going so rapidly, and the most important thing, no vaccine for mRNA virus has ever been a major success. So there's a lot of caveat regarding COVID-19. We have to be optimistic, but we have to have a lot of caveat when we are more optimistic.
Dr. Yadav, one more question is that, do you think that if we do serology and if we identify population, somebody is having IgG against say COVID-19, another group is not having IgG, and you isolate the IgG positive group, you know that they are completely immune to the virus. Is it applicable in the society? That is a question which many physicians are thinking.
The most important thing, when you have a single strain of virus, same thing which is happening in dengue fever. We believe that once you have a dengue, you will never have a recurrence. And now what we are seeing in Delhi, people has 3-time recurrence with dengue. So until you have a single virus, I don't believe, I'm not a great microbiologist, I'm a cardiologist basically, but what my basic knowledge says, if it is changing their strain rapidly, I don't think a particular immunity will make you immune from lifelong for this virus. So I may not be an appropriate person, but whatever my knowledge says, it is a presumption which actually will not become a reality.
And the last question for you, do you think the cost of healthcare,
You are muted, doctor.
Yeah. Yadav?
Yes. No, that is very true. basic thing is what we have to understand and what we differ from UK and USA and all the developed countries, that we believe that the COVID-19 is an upper class and urban disease. Now, what is happening at present in India? We believe that in near future it will be a village disease. This will spread to the remote area of this country. So the healthcare policies which need to be made in India need to be made for primary and secondary. We have a PP names. We are the most privileged institution in this country. But think of a district hospital, and I think if you think of district hospital, go a remote medical college, you will be surprised to know that they have even not a basic mask, which is a triple layer mask with them, and they are seeing the patient. So if any policy, because it is a huge economical burden on a society. At present, if you think one PPE for 6 hours is costing 2,000 rupees. And if you have a 5 ventilation patient, you can calculate the amount of cost which is involved in this PPE. So it is easy to say that provide PPE to each in healthcare. But if you see the economical burden on the country, it will be enormous. So we have to frame a policy, not seeing some few 10% affluent hospital, but because this disease is now reaching to the remote area, and probably it will reach what everybody is presuming it will reach. So make the policy, but it's not easy to say that in OPD make a social distancing. And I always say, don't use word social distancing. Use word physical distancing. It is not a social distancing. We cannot be socially, and Dr. Sajoy has very clearly says, I think he is also a believer, we should not say social distancing, we should always say physical distancing. So yes, you are right. If you do not, and the healthcare facility for fighting any pandemic cannot be made within 3 months or 6 months. It is a sustained healthcare improvement over years which works. So if you fund a lot of money for 1 month and then you don't sustain your healthcare facility for a long time, and the second important thing, I have a discussion with a lot of nursing home owners. Why you don't make CCUs? Why you have no good CCU facility? They say running a CCU is a very costly affair. It is not viable for us. So it is easy to say increase your CCU facility, but how they will be increased, because you all know it requires a lot of funding, lot of money. So this all holistic approach has, including the primary healthcare, secondary healthcare, district hospital, medical colleges, small nursing home, which are treating common diseases. So this all has to be redefined. A new SOP has to be formed, and we should always go beyond what at present we are thinking, because I don't know, this virus can change. This virus, what in near future it will come as, we don't know. This is all our speculation.
Thank you, Dr. Jalal. Quick question to Dr. Kalra. Sort of he has already mentioned about the cost. We are talking about, this virus is coming. There is a admission of the patient, or COVID-19 patient, and then patient, some of them, they are getting worse, they may probably die, some of them they go back. Is there any recurrence, readmission, rehospitalization, and mortality? One. And what about the coexistent sort of comorbidity and COVID? What are your experience and your thoughts, Dr. Kalra?
So an answer to the first question, I think the shortest joke in the world is COVID expert, because we just have no idea. Our experience so far has been no reinfection per se, but lots of prolonged positives. And it's not clear whether that's fragments of the virus that will grow as part of the PCR test, but that are non-infective, or if they're truly still infective segments of the virus. My patient this morning, who I was called in to see, unfortunately died because he had really bad lungs, and I couldn't put him on ECMO. He was infected with COVID on May 5th. It's been a long time now. He was infected May 5th, got better, and then on the ward got worse, bounced back to the intensive care unit, and then died. And it's not clear to me whether his rising inflammatory markers were a marker of a super infection from something else, his bad lungs in a fibrotic phase of the disease, or a reinfection. We have no idea. And we have to be honest about that. That's why I say transparency is important with the patient populace, so people understand that we are working through it as best we can. As far as the comorbidities go, the unspoken sort of elephant in the room, if you will, The big comorbidity that seems to result in really bad outcomes is obesity. If you're heavily overweight, you have bad outcomes because your lungs don't expand, you get more atelectasis, and you get really, really bad SOCT and ARDS. Now, the things that in the community that seem to have been studied in detail have been cardiovascular disease, which certainly carries with it a higher rate of adverse outcomes with this virus based on the epidemiology that we have. We don't know whether or not it's cardiovascular disease per se, or the confluence of risk factors that result in cardiovascular disease: smoking, diabetes, hypertension, obesity. And that, I think, remains to be parsed out with data collection and analysis in the days and months and years ahead. Who know? The other thing that we don't know actually is if you recover from this. And I remember I was a resident during H1N1 when it hit Toronto, and there was a clinic for H1N1 survivors. They never had normal lungs again. So we don't know if those who are infected will be themselves a year from now, right? There's a lot of big question marks, which is what underlies the need to concentrate on very careful physical distancing and the development of alternative methods to remain social creatures, because I think we lose our minds unless we do.
Thank you. Last question to you. What about your care with non-COVID patients during this pandemic?
Yeah, great question. So we shut down, as many institutions in our side of the world did, we shut down elective cases for quite some time. The evidence for coronary disease, which is the one that people are most worried about, right? What's going to happen to the people who have chest pain at home, as you very well know. Stable coronary artery disease is a symptom problem so long as you have normal heart function. And quality of life is an important outcome, but it is not death that you get if you have stable coronary disease in the short term. And that's coming as a CTO operator who does nothing but complex coronary disease. But emergency cases, STEMIs, non-STEMIs, cardiogenic shock, these things, they still go. And they still go when they have to go, because that's our job. Insofar as the elective surgeries that we have to deal with on a regular basis now, we are starting to bring in our urgent electives, right? The people who are really having severe symptoms that need to be done because their quality of life is so badly affected that they are now questioning whether or not they can continue with their life, right? Quality of life is an important factor. That slow rollout is what's happening at our hospital, and it remains to be seen if we have a second peak because there are other people who don't understand the same things we do or don't believe the same things we do, and we have to shut down again, or if that slow, careful, and planned rollout is successful.
Thank you, Dr. Kalra. Dr. Nandi, a quick question to you about the cost, because you talked about the branding, you talked about the revenue drop. So do you think by having branding, self-branding and hospital branding, the cost will go up, or even the healthcare cost in general during this COVID or post-COVID era will be unaffordable to some community? What are your thoughts on that?
I think the worst is over. Like Dr. Yadav correctly said, these PPE are expensive and we need a lot of PPE, but the hospitals in India, and we are talking about India right now, where we do not have Medicare and Medicaid and the government to fund, have to realize that there will be no dollar profit or money profit this year, but they need to become aware of the losses and they need to set target goals. At the same time, optimize COVID treatment and non-COVID treatment. So they need to slowly, as Dr. Kalra just said, they will start getting in new patients and people will stick their neck out and start doing the work for patients and slowly phase in. They will see their profit come in. And there has to be an appropriate balance. But everybody has to be able to call a spade and realize that there will be no profit this year. It is impossible to make profit this year, but they will have to become aware of the losses and how these elective procedures can cover the cost of the PPE in order to optimize the care of the COVID patient so that the branding of the hospital is done and the hospital do not be perceived as a short-term goal, but a long-term institution to be recognized and to be seen as. That's my whole concept.
Right. I think the question, as you might have seen, from Mr. Tushar Kanti Viswas is that you talked about branding and promotion, which of course it incurs a lot of cost, but the hospital occupancy is low. The beds are empty. So how sort of the revenue we can generate? And each the procedure, for example, today an angiogram, angioplasty, even an orthopedic surgery, neurosurgery become expensive as compared to the non-COVID, the earlier situation. What are your quick thoughts?
Yeah, so like basic things, wash your hands, maintain, and I like the word physical distance. From now onwards, I'm going to use the word physical distance and social distance, because the social distance has a psychological, mental component in it. Maintain the appropriate physical distance, education, a lot of media education is required. Media needs to become a partner and be able to call a spade, that these things can be avoided by not having handshakes, using namaste, using judgment, see, a lot of judgment call, and then slowly start taking risk. Life is full of risk, pragmatic risk, you know what I mean? Get the patients in, get the elective work done, and move on. I mean, that's what has to be done.
Thank you. Thank you.
Thank you very much.
Chakraborty, every speaker touched upon this point that there is a bit of sort of, you know, people are obsessed to do hand washing, you know, putting masks, wearing gloves, every bits and pieces, and even medical professionals. After they come out of the hospital, many of them are not being allowed to enter their own apartments. So, how do you think the society is getting mentally, sort of, there is mental unrest in the society. There's an anxiety in an individual. There's an obsession. How do you think the psychiatric or the psychological, the situation of the population because of COVID-19 around, and how it is going to continue for a longer period of time? You have to unmute.
I was saying that, were you asking me about the long-term impacts on kind of obsession with hygiene in society? Is that the question?
That do you think there is a bit of obsession involved? Because people are obsessed to wash their hand, putting gloves and the sanitization. Do you think this is an obsession, a kind of a disease coming in? Do you think that many people are anxious? Everybody's thinking every bit, somebody's coughing 2 times since it's COVID. Somebody's having little temperature, thinks COVID. So this is the society as such, its community is going towards a psychiatric abnormality or psychological abnormality. What are your thoughts?
Oh no, definitely. I think that's a very interesting discussion, because I think now we don't know what appropriate social anxiety is. I mean, I'm so terrified of going to the grocery store. I go to the grocery store and someone tries to hold the door open for me and I'm like, don't touch me! I think it is unfortunately the new normal. I don't know in terms of addressing it. I don't think that, that we can invalidate other people's anxieties by saying, be this way or feel that way. I think it's appropriate to say, okay, there are certain rules, 6 feet, mask, gloves, done. But I think that it is acceptable right now to feel that way. And I think it's okay to feel like that.
So this kind of anxiety, do you think is acceptable to the society for the time being? Because we, the non-psychiatric doctors, are seeing patients, young patients, coming with sort of vague chest pain and asking for an angiogram, for example, which is not acceptable to me as a cardiologist. What are your thoughts?
Well, I think culturally in this day and age, I don't think it's unacceptable. I think it's too early to treat this kind of anxiety. I would just normalize it unless it's reached a point where it's causing panic attacks or it's causing significant deterioration in functioning.
Right. There is a question to you by Mr. Devraj Hajra saying that during this lockdown period, all children are bound to stay at home, and they are thinking that that the parents are not letting them go out for no obvious reason. Many of them are having educational academic coaching by video online. Do you think there is a psychiatric or psychological impact to the children because of this?
I mean, because their parents are not letting them go out, you mean?
A, and B, that the children are allowed to stay at home because parents are asking them not to go out, to play, not to move with other children. Do you think there may be an impact? And at the same time, they're staying at home and having academic education from by online. Do you think this is the right thing? Do you think that academic education may have some, because there's the mixing with their peers? So do you think that could be a problem psychologically?
I think that it is a big adjustment for kids to learn via this platform. It doesn't feel right when the weather is good again and you want to go out and you want to go biking with your friends. So I think it is having a detrimental effect on kids' mental health. In terms of how to address it, that's a bit of a challenge. That's when they have to come to see me. We have to come up with a plan that'll work for both kids and parents, come up with activities that are safe, but are also enjoyable and acceptable. So I'll give you an example. I have a family that I work with. My patient has ADHD. He is obsessed with video games, like all ADHD kids. It's a stereotype. He wants, I mean, if he had his way, he'd be on a screen for 8 hours. And now this is his dream. He's getting to play Fortnite 8 hours. I mean, it's not 8 hours. So now we're coming up with ways to structure video game time and outdoor time that is safe, that's within physical distancing guidelines, only with his siblings, only during certain times, only at a certain place. And we're trying to make it work. But it's being done in a structured way, and we're addressing it in every session.
Before I move to Angela, there's a last question to you. I mean, we are seeing in India that a lot of the younger generation, even working at IT industries or working in marketing, even in medical professions, what happening since some of them are going out and handling COVID-19 patients. Some of them are not going out at all, working from home. So what is happening? Many of them are coming out with kind of vague ideas, and some of those ideas could be suicidal ideas. Do you think this is because of the effect of COVID-19, or it is just a coincidence of them anyway, perhaps that made it unmasking? What are your thoughts as a psychiatrist?
Oh, I need more information are you suggesting that they're getting depressed because of COVID?
I don't know. I'm sharing my observation. So what do you think that the people who have a kind of an ideas inside may come out or maybe unmasked because of the pandemicity of COVID infection?
I don't know the answer. I can only speculate. Because I think that the pandemic has stirred up a lot of uncomfortable feelings for a lot of different people. I mean, for one, I know that, as a physician myself, and I'm not in the front lines, like a lot of the others, but a lot of physicians that have not been doing frontline work have been feeling guilty, and that's caused a lot of negative feelings. And I say this because, I talk to my colleagues, and we talk to each other, and I support other physicians that are on the front lines. I've seen other individuals that, have begun to question their identity, their existence because of COVID, and their depression has gotten worse. Again, I don't know if that has if there's any real statistical, I don't know if that's what the question is, but it certainly stirred up a lot of negative feelings in people.
I think there's one more question from Sneharshi to you about the digital access, inability to have digital access for children in India. You can just quickly, just in one sentence, can answer this question, that in India, most of the people have no digital access. How can they overcome it to give their children's education class to Dr. Anindita? This is a question to you.
This is a really good question. I mean, the best you can do is buy books of that grade level and review some of the basic material with your kid at home, if you have time.
Okay, so anything else?
Those are really good questions.
Yes. So if because Snehashish is looking forward to having an answer. You got any other answer? There is a question to you. There are also fear of psychology among the doctors and healthcare workers to handle COVID patients. How to improve? That is to you. Psychological fear of doctors and healthcare workers. Can you answer this question very quickly?
Yeah, there's a fear of, is there a fear of doctors with COVID, you mean?
It is in the chat box. You can see very clearly. This question is being seen. Tushar Kanti Biswas asked this question.
There is also fear psychology among the doctors and healthcare workers to handle COVID patients.
Yes.
So I'm going to interpret that as that people are afraid of doctors who are taking care of COVID patients. Is that the right way?
No, it is psychology among the doctors. If doctors are having fear to treat patients. So what is your suggestion?
So that is
nurses and others.
That's a very challenging that's a very challenging question, because it sort of makes you ask yourself, why did I choose the profession in the first place? It brings up a lot of difficult feelings. But I mean, if you've signed up for something, then I wouldn't say this to my patient, but if you've signed up for something, then I guess you just have to do it.
I think we move to Angela. Angela, you got something to say. Angela, can you unmute? And
hold on. I have another question.
Okay, quick answer. There's a time here. You don't have much time. Okay,
major depression, panic attacks, OCD, PTSD, how to treat after lockdown is over. So I wouldn't change treatment algorithms for major depression, panic attacks, OCD, or PTSD. Honestly, I mean, I would still go with standard of care. I would still go with CBT and medications, panic attacks, medications, OCD medications as needed. I would simply change the context of the treatment if it revolves around the pandemic specifically. But
so basically,
I haven't trained. So for instance, I have a patient, and I don't think I talked to you about this. I have a 12-year-old boy that I treat with major depression with Lexapro, and he's also in a CBT. And his symptoms just got worse because his mother happens to be a nurse. She was working in an ICU, and he was terrified, just terrified that he would lose her. His suicidal ideations got worse. He began to start hearing auditory hallucinations. We didn't change his treatment. We just went up on his Lexapro, and we just embraced what he was going through at, in the here and now.
Good.
Psychological.
I think now from the mental side, I'm going to different.
There's another question.
So I will come back to you. Maybe then Angela has to answer. Do you think in the foreseeable future, with COVID-19 around, there will be application of digital technology, artificial intelligence? Even some of us healthcare workers can also be allowed to do work from home. What are your thoughts, especially on the digital part, digital technology, and implementation of artificial intelligence? We never touched upon this point.
Yeah, I mean, I think this is a huge opportunity, really, because we have started doing a lot of work potentially from home. Our hospital gave us trust laptops, so they're very secure, and on them we can look at patient records, patient notes. We're very much electronic in terms of our record keeping. We also have access to a limited amount of the information from primary care, so I can look to see what medication people are on. I can find out their telephone number and I can ring them. And actually it's been very successful, and the patients really like it because they get a lot of reassurance just from knowing that there's still communication there. I think communication is the key to a lot of all of this. Communication between colleagues, between colleagues and their patients, between colleagues and the relatives of patients, particularly the sick, the very sick patients. And so whatever we can do to improve the communication, that is undoubtedly for the better. What we now need to move forward towards developing is the ability to undertake diagnostic, so in other words, clinical examination remotely. And that's probably the next stage, because I can telephone my patient who I did a PCI on, and I can check that they get no more angina, and I can discharge them after I've checked their medication. That's fine. But
Great.
what I can't do is I can't examine the patient with valve disease, for instance.
You're so right. And just we are going to close the session because time is up, 9 o'clock in Indian time now. Just before I close, just one quick question. In the UK, teleconsultation is legally permissible?
So we had emergency guidelines, essentially. So the GMC produced some guidance, the defence unions produced some guidance, because there were all sorts of ramifications for COVID-19, because there was telephone consultation. So we have to be very clear that we have documented exactly what we've done. And people that need face-to-face, they still need face-to-face. So it's not that you're denying them the face-to-face. It's right. That we will only do the telephone consultation when it's appropriate.
Rakesh, is it teleconsultation, video consultation is ethically or sort of legally permissible in India?
There is a recent guideline in India which has been given by Ministry of Health. So that guideline has certain things which you have to do. But for a long term, if it is permissible in a sick patient, how will you give a prescription? Because majority of the patients don't have a printer to take a prescription. How will they get the money? How will they get the reimbursement? How will they buy the medicine? Because many medicine without prescription, you cannot get it. So there's a lot of caveat in general. But yes, at present, there is a guideline. So if you want to do it, you can do it under a law.
Good.
There is no
Dr. Nandi, you do a lot of teleconsultation. What are the legal standing of teleconsultation in USA?
Oh, because of all the regulations have been removed. Previously, a physician licensed in New York could not see a patient in California. Now the interstate license has been removed. So a physician licensed in New York can see a patient in all the 50 states. Number one. Number two, Medicare only paid if the patient was located in an Article 28, that is in a healthcare institution and in a rural area. Now, if the patient could be at his home and you could be seeing the patient and you would get paid actually more than a face-to-face visit, because you get paid at the professional component and the technical component. So you get almost 1.5 times more payment through telemedicine. Number three, you can optimize your schedule. We are seeing a lot more patients, and we provide these telemedicine services to 800 nursing homes throughout the United States, and our number of consults have increased by almost 4 times. And we are doing all the scheduling, billing, and everything of these patients from Calcutta, India. And in my workers in Calcutta.
Thank you. Sanjog, are you doing teleconsultation in cardiology?
Oh yeah, it's the backbone.
This is legally permissible.
Yeah, it's the backbone of our outpatient work right now, because of, just as Dr. Nandi pointed out, a lot of the regulations, I don't want to say necessarily removed, because it, that I think not removed, but optimized, right? So that, billing and these kinds of things can be done with the right documentation present. We have to document in the note that we have the patient's permission and consent to do a telemedicine consult. But there are apps here. Doximity is an excellent example where it's almost seamless video face-to-face consultation with a text message sent to the patient's phone, which they then click on, and instantly it creates a video link. That is a live video chat just like this one. It's no different than Zoom.
Okay,
and there are ways actually to monitor people. Right. You can't listen to their heart, but you can certainly look at their ECG.
Yeah, Anindita, what about Michigan State? Is it legally permissible? Michigan.
Yes. Yes.
Legally, you're allowed to do teleconsultation.
Yes, I mean, we don't even have to get paper consent.
All right.
Verbal consent is enough. Yeah.
Okay. So I think this is it's more than 9 o'clock in Indian time. I think I find this meeting extremely helpful, and our chamber is going to record it, the entire thing. Angana, can you so make the conclusion, and then we can close the session, and have a good time in the UK, in US, in New York, Philadelphia, Michigan, and me, Dr. Chakraborty from India. Angana, can you just close the session?
Yeah, thank you everybody for joining. As Dr. Chakraborty said, we have recorded it and we'll try to put up the video in our YouTube and Facebook, and we will share the proceedings. Thank you.
Thank you.
Thank you very much. Thank you. Thank you. Thank you being very, and thank to all the audience. Thank to the organizers. Thank to the support team and the technological support, Angana and Angana's entire team, the Subhadeep, even the president, and Dr. Alok Rai being our mentor. Everybody's input designed this program. It took a lot of time for us to design the program. Thank you for our overseas faculty to support this program. It's going to be extremely educative and extremely helpful for us, for the chamber, and we are going to share and we are going to pass our information to the regulatory body, to the governing body, as well as to the community in general. Thank you very much. I express my gratitude to every staff of the Chamber of Commerce, to the support team, to the technological team, and to every sector audience. A huge number of audience participated. They came and went, The total number, I'm sure, is good. So on a Saturday evening, such a participation is great for all of us. Thank you very much. Have a good day, have a wonderful weekend, and stay safe, stay healthy, and continue to be obsessed. Continue to be obsessed with your hand washing and social distancing, and also, the other precautionary measures as per the guideline. Thank you very much. Thank you. Good night from India, and have a good time in our country. Thank you. Take care of yourself. Thank you, Sanjog. Thank you, Anindra. Thank you, Angela. Thank you, Dr. Nandi.
You're welcome.
Thanks, Rabin.
Thank you.